Okay, so once again, good evening, everyone. So we're back for the MDS 360 degree with a 1 hour session, live sessions, which take place every day, 7 days of the week. Each day, a new subject, a new topic from the dental faculty. So myself, Dr. Rijul Agarwal, I'm the orthodontic faculty at DAMS. So today we are going to discuss classification of malocclusion. As I said every time, a really important topic, and I'll highlight you the questions which came in the recent 2-3 years, most recent being the AIIMS May, CET May MTS exam. Okay, so I hope these sessions are useful and informative for you, and they take you a step closer towards your dream college and seat and give you an edge. And once again, if anyone has any doubt, can write in the comment section, or you can message me on the group, on the club, or WhatsApp, anywhere, and we'll be happy to help you out with it. Okay, so let's start. The topic is classification of malocclusion. We are going to discuss various classification systems, starting with the basic, the angles one, moving towards the premolar, the canine system, the incisor system of classification, the 3D system, and the various acumen, profit, and the various other systems of classification of malocclusion. So beginning with the basic thing, what is overjet and overbite? As we all know, overjet is the horizontal overlap of the anterior teeth, and overbite is the vertical overlap of the anterior teeth. How is it measured? It's shown in the image, the vertical and the horizontal overlap. So similarly, as we have a overjet and overbite in the anterior region, similarly we have a overjet and overbite in the posterior teeth as well. So this is the buccal overjet, the distance between the buccal cusp, the tangent drawn to the buccal cusp of the upper molars to the lower molars. Okay, so this is the buccal overjet. Okay, so similarly, what is scissor bite and cross bite? When the upper teeth, the posteriors are linked palatal to the lower ones, are in cross bite, and when there are buccal, then it is a scissor bite. Okay, so what is incomplete and complete overbite? Incomplete overbite is the one in which the lower incisors fail to occlude with either the upper incisors or the mucosa of the palate when the teeth are in centric occlusion position, that is in maximum intercuspation. And complete overbite when they contact the palatal surface or the tissue of the upper palate in the centric occlusion. Okay, so what will happen when these teeth touch the upper incisors or palate? They result in trauma to the upper incisors, or there is inflammation in the palatal region, and this is the most common cause for the patients to undergo orthodontic treatment, because having a deep bite is the maximum prevalence in India. You can see nearly 99%, 95 to 99% have this kind of orthodontic problem, and this becomes a functional cause for treatment, apart from the aesthetic reasons for which patients are undergoing orthodontic treatment for. So beginning with the first, that is the angle system. So how come angle arrived? You all know what is angle system of classification of malocclusion. We'll come to that. So before beginning that, describing that, how did angle came to this system of classification? Okay, so for that he gave us two concepts, that is line of occlusion and harmony line. So what is line of occlusion and harmony line? The first image, this depicts the line of occlusion. So it is the relationship between the upper and lower arches, the harmony line. Okay, it describes the relationship between the upper and lower arches. So what it says that the dental arches, the upper and lower arches, assume the shape of a catenary curve. So what is a catenary curve? I have already discussed this in my previous lectures. Catenary curve is a mathematical term used to describe when we hang a piece of chain from a rod. So the shape which this chain assumes is known as a catenary curve. Okay, so he said that the arches assume that shape of a catenary curve, and according to this line of occlusion, the in upper arch, this line of occlusion passes from the curvature of anterior teeth and central fossa of posterior teeth. Okay, so from incisal edge to the central fossa of the posterior teeth. Okay, and similarly in the lower they passes from the buccal cusp of posterior teeth to the incisal edges of anterior. This is the line of occlusion in the upper and lower arches. And next concept which he gave was the harmony line. So what is a harmony line? So according to angle, he took the profile. So this is the image of the profile of a Greek god. Okay, Greek god Apollo. So he was a mythological god. So according to him, this is the ideal profile, and the aim of the orthodontic treatment should be to achieve this profile. Okay, so that's why these two things, and line of occlusion and harmony line, played a pivotal, or you can say the most important role in describing or giving his system of malocclusion and rest his treatment. Remember, from evolution of orthodontic appliance, he was a strong advocate of non-extraction therapy. Reasons are this: because his concepts was based on these two, line of occlusion and harmony line. So according to him, the aim should be to achieve this kind of dental tissue occlusion, and the profile of the patient should be like this. So if he had undergone, the patient would have undergone extraction, the teeth or the lip would have fallen back and the profile would have been spoiled. So he believed in expanding the arches. Okay, if you remember E-arch, ribbon arch system. Okay, these were all based on the concept of expanding the arches to correct the crowding and never on extraction of the teeth. Okay, it's because he believed that the aim should be to achieve this kind of profile for the patient. Okay, so similarly, a question to make you understand one more concept: identify the green colored curve. So I just described this one, line of occlusion. So what will the green colored curve? Following the facial surface of the maxillary teeth. So this is the aesthetic line of dentition or occlusion, which follows the facial edges of the anterior and the posterior teeth, and it is used to incorporate the tooth lip relationship into the diagnostic evaluation of tooth position. Okay, so this is the green colored or the aesthetic line of occlusion. Okay, so this is not catenary curve line of occlusion, I've already described, and E plane, it's the Ricketts E plane from cephalometry. Now I'm not going to describe what is class 1, class 2 and class 3 molar relation. You all know from your graduation time. So the other name for class 2 and class 3, so for class 2 molar relation, it is also known as post normal occlusion, and for class 3 it is also known as pre-normal occlusion. Just remember these names. Okay, next comes this table, which is very important, the differentiating features between class 2 division 1 and class 2 division 2 malocclusion. Okay, so before beginning, you all know what is class 2 division 2 malocclusion. Okay, in which the upper incisors are retroclined, leading to decreased overjet. If anyone doesn't know class 2 div 2, just write, I'll explain what is class 2 div 2 and class 2 div 1 before beginning with the differentiating features between the two of them. Okay, so everyone knows what is class 2 div 2 and class 2 div 1. So these division 1 and division 2 of class 2 malocclusion was done by Engel himself. In the upcoming slides we'll learn about the subdivisions of class 1 and class 3. They were not given by Engel, but class 2 div 1 and div 2 was given by Engel himself. So this was the first MCQ question. Next comes the features of class 2 div 2. So the most important thing, or the most important thing about div 2 is its characteristic feature. So its characteristic feature is retroclined incisors, the retroclined, more specifically upper incisors. Okay, and if the question comes about most pathognomic feature, what is pathognomic, most dangerous or most harming feature? It's 100% deep bite. Mostly patient will come to you for this treatment, for correction of pathognomic feature, not for this retroclined upper incisor, because retroclined upper incisors means increased incisor visibility, and increased incisor visibility is indicative of a youthful smile. Okay, so 100% deep bite, as we have already discussed, leads to lower incisor attrition, palatal mucosa inflammation, okay, ulceration in the palatal mucosa and all that. Okay, okay, so one student has just joined, I think. Good evening, sir. Okay, good evening, Komal. Okay, so as I was telling about the characteristic and the pathognomic features. Okay, so just be careful what is asked in the MCQ, characteristic feature or the pathognomic feature. Coming to the differentiating features between the two of them, so the profile is convex in div 1 and it's straight to mild convex in div 2. The features of the lip, the upper lip is short in division 1 because of the procline, its division 2 is normal. Lower lip is everted. Why? Because the upper incisors tend to impinge on this, leading to eversion. Eversion means outward flaring of the lower lip. Okay, now they are incompetent because of the proclined incisors, and in div 2 it's competent. Now the mentalis muscles is hyperactive in div 1, whereas it is not there in div 2. Why? The upper lip is short, the lower lip is everted, leading to increased interlabial gap. So what will happen? The mentalis muscle is here, so it becomes hyperactive. Hyperactive means increased activity. Why it will have increased activity? To bring about good lip seal. It will try to achieve lip seal. That's why the lower lip or the mentalis muscle becomes hyperactive. हर चीज का just try to understand the logic or reason behind it and becomes easy. You don't have to mug it up कि एग्जाम में अगर आपको लॉजिक रीजन समझेगा, once you see it, it's done. Okay, that's why this table is totally based on the logic. First need to remember upper incisor proclined in div 1, they are retroclined in div 2. Retroclined होंगे तो क्या होगा? Deep bite होगी. That becomes the pathognomic feature. Retroclined हो गए, deep bite हो गई, तो upper lip और lower lip competent हो गए, normal हो गए. उसमें proclined है, the upper lip becomes short, lower lip becomes everted because of the upper proclaimed incisor, and the lips become incompetent, leading to hyperactive mentalis mac. Simple. It's like a story. Next, coming to the cephalometric features, the lower facial height. So in div 1 it is normal or increased, whereas it is decreased. Because why? Because in div 2 generally they are horizontal growers. The arch form is V, and in div 2 it is generally square to U shape. The mentolabial sulcus is deep. It can be deep or normal in div 2. Why deep? Again, this is the mentolabial sulcus, this region. So once the lower lip becomes everted, this region becomes deep. Simple. Whereas in div 2 it can be deep or normal as well. Okay, I hope it's clear. Lip trap. Correct. The lip becomes trapped between the proclaimed upper incisors. Okay, but lip trap is Komal more of a habitual position. It's not always a feature. That's why I haven't mentioned it here. Okay, lip trap is somewhat habitual, that the patient continuously present, the lip becomes entrapped between, and that happens in the when the incisors are too much proclaimed, when the overjet is increased too much, so that the lips become trapped between those three. So it does not happen all the time. Lip sucking and lip trap, these are more of a habit, oral habit kind of a feature. So you are right, but partially right in dip. Okay, so it does not become a feature. Features are the one which are always present. Okay, so as I was telling, the lip trap is trapped behind the upper incisors. Moving ahead, so what is Sunday bite? Sunday bite is the one feature in which it was, first of all, if you all know, this was a very common question during your final year exams. Sunday bite. So what is Sunday bite? Sunday bite is a feature when the patients tend to move the mandible forward to attain the lip seal. Okay, so it is was generally done to camouflage an underbite, that is class 2 or retrognaths. Okay, so similarly, like Sunday bite, we have another thing known as bite of accommodation. Okay, bite of accommodation. So what is bite of accommodation? So in Sunday bite, what the patient does is move the lower jaw forward to attain the lip sweep. In bite of accommodation, again the mandible is postured sidewards. Why it's done? Because of the presence of cross bite. So remember this term as well, bite of accommodation. So it is done when the patient moves the jaw laterally, either left or right, so as to achieve maximum intercuspation. So I hope Sunday bite, bite of accommodation, lip trap, and the features of div 1 and div 2 are clear. Moving ahead towards another thing that known as column angle. This is the feature of class 2 div 2. What is column angle? Another very important MCQ. So column angle is the angle between the crown and root of the teeth. So it's generally present in class 2 div 2 and class 3. So students, what happens is the root and the crown are not always parallel to each other or in a long line. Sometimes they are at an angulation with each other. So when a line is drawn bisecting the crown portion and the root portion, they form an angle. So this is known as column angle or the crown root angle. So in division 2, what happens? As I said, the incisors are retroclined. So what is there is the upper incisors are retroclined, the roots are normally positioned in the bone. So that's why when we are doing treatment of division 2, class 2 div 2, we have to take care in mind, we have to look at the lateral septum or the radiograph of the patient, that so that when we are proclining the upper incisor, the roots does not come in contact with the cortical plate of the palatal bone. Okay, so that is known as column angle, and it is generally increased means this angle is increased in class 2, div 2 and class 3. This column angle exists in all teeth, but it is not so much. Okay, it is generally increased. If you ever take a lateral ceph or a cross section radiograph of a patient, you will be able to appreciate this column angle, mostly on a CBC. This column angle is present in all the teeth. Okay, so it is generally increased in first class 2 div 2 and second class 3 malocclusion. So class 2 div 2 में upper incisors में, class 3 में lower incisors में. और अगर ऑप्शन में दोनों ही हो div 2 and div class 3 तो div 2 most appropriate or most correct answer than class 3. Okay, so I hope this confusion is clear कि pulse में ये लिखा है something like that, something. Okay, moving ahead. So as I told you, div 1 and div 2 were the modification or subdivision given by angle based on the increase and decrease in overjet. Similarly, Dewey gave modification for class 1 and class 3. Dewey was also a student of angle only in Angle School of Orthodontics. So he gave classic modifications for class 1 and class 3 malocclusion. So instead of division, he gave the term type. So type for class 1, he gave it 5 types. Type 1 is for crowding, 2 is for proclination, 3 is for anterior crossbite, 4 is for posterior crossbite, and 5 is for early loss of deciduous molar leading to mesial drift of permanent molars. Okay, and 3 also, as I have told you, pre-normal occlusion. Type 1 is H2H, 2 is lower incisor crowding and lingual to maxillary incisors, 3 is upper incisor crowding and crossbite with respect to mandibular anteriors. Okay, so this is the theoretical part of classification. एग्जाम में क्या पूछते हैं? Now earlier days, मतलब 5-10 years back, direct question इस पे आ जाते थे. You must have seen the previous. Those who have done this, seen the previous year, would have seen. Now what they give you is a image based question to classify into subtype. Okay, और image में क्या present होगा? Image में crowding भी होगी, proclination भी होगा, हो सकता है anterior crossbite हो या कुछ भी हो सकता है ये भी हो. So how will you classify? Now there is crowding also, proclination also, शायद anterior crossbite भी हो, posterior भी हो, और worst case scenario deciduous molar का loss होने की वजह से 6 mesially drifted या tipped भी दिख जाए. So how will you classify? If anyone can tell, otherwise I'll complete it and move ahead. Okay, so no one is answering. Moving ahead. So अगर ऐसा केस सिनेरियो है, so what Dewey or what these classification systems are based on, they're based on increased severity of the class malocclusion. So if all of these are present, so you will classify it as type 5, or type 5 will be the correct. And so what, in the reducing order. Okay, if this is not present, posterior crossbite is present and ऊपर सब कुछ है, then type 4 will be the correct. So these are classified into increasing severity. So same goes for class 3 as well. Coming ahead to the next, that is bimaxillary or bimaxillary dentoalveolar protrusion. Okay, so there are two terms, bimaxillary protrusion and bimaxillary dentoalveolar protrusion. So if bimaxillary or dentoalveolar, that means the dental arches or the dental teeth are forwardly positioned on a normal skeletal base, and bimaxillary prognathism means both the arches are forwardly positioned. Okay, bimaxillary prognathism mostly is seen in African population, and the treatment is surgical option only, whereas dental protrusion is mostly seen in Indian population, for which patient comes to you for treatment. So for the treatment would be simple, all first premolar extraction and retraction of the anterior teeth. Okay, so what with the three clinical features of this dentoalveolar protrusion? There will be excess lip separation at rest, that is more than 4 mm. Okay, the patients will have excessive effort to bring the lips under closure, that is leading to lip strain, and the upper and lower lips and the dentular area in profile view would be prominent, that there will be a highly convex profile will be present because of the proclined incisors. Similarly, class 2 division 2 van der Linden subclassified it into three types, that is type A, B and C. So A is when upper incisors are retroclined, there is no crowding and canines are normally aligned. B is central incisors retroclined, lower incisors labially tipped or overlap the central incisor. C is all four incisors are retroclined and canines are labially positioned. Okay, so what is buccal crossbite? That is cross occlusion, another term, that is a cross occlusion observed by Barrett in Australian Aborigines. Okay, so this is also known as Barrett's bite. तो अगर एग्जाम में कहीं Barrett's bite करके टर्म लिखा है, सॉरी फॉर माय हैंडराइटिंग, so don't get confused. Next is controversy of subdivision. So what is controversy of subdivision? The subdivision occlusion occurs, we classify it as subdivision when supposedly, you must have seen in your OPD as well in your college during your internship, that there is class 1 molar lesion on one side, class 2 on the other, or class 2 or class 3 or 1 or 3, which is also possible and likely scenario in many of the cases. So how will you classify it, whether you say class 1 or class 2 or class 3? So Angle gave the term subdivision for this thing. He said that in cases of unilateral malocclusion, where one side is normal, other is not abnormal, we have to use the term subdivision. But he did not mention which side to be classified as normal and which side as abnormal. Whether if there is one and class 1 and class 2 molar relationship on right and left side, which is normal, which is abnormal, or class 2 or class 3, which is normal, which is abnormal. He failed to mention that, and he was a strict personality, so no one dared to even question or ask him to complete his logic. Anyhow, moving ahead, so for exam, how will you classify? Supposedly an image like this comes. So for exam, the affected side is the subdivision. So supposedly there is class 2 and class 1 molar relation. So class 2 on the right and class 1 on the left, like in this image. See, what you will write is class 2 subdivision on right side. This is how you classify. Okay, if there is class 2 and class 3 molar relation, class 2 on right, class 3 on left, so you write class 3 subdivision on left side. So 1, 2, 3 increase in severity, increasing effectiveness. I hope it's clear for your exam point of view, because these things come as images question. Simple thing, they ask you in image form to classify and take the correct answer, mostly in INI CET. They just love these image based and these classification questions, which are very simple because all of you must have done them, but they just twist them in image form. Okay, moving ahead, that is functional or pseudo class 3. So what is functional or pseudo class 3? Pseudo means false class 3. That is, the molar relationship is just a minute. So as I was telling, functional or pseudo class 3. Pseudo means false. So what is false class 3? Means the molar is class 3 but the skeletal base is not class 3. So why this happens? So in true class 3, as I said, that there is a skeletal disharmony along with the molar relation according to the problem. Whereas in pseudo class 3, there is molar relation is class 3 but the skeletal relationship is not class 3, that is the mandible is not forward or the maxilla is not. So why is the molar coming as class 3? So it is because of skeletal dental prematurity. So what happens is, while closing the mandible, due to some dental prematurity or premature contact, the patient tends to shift his mandible forward so as to achieve maximum intercuspation. Remember, as I told you, bite of accommodation in cross bite correction. Similarly, in pseudo class 3, due to dental prematurities, the patient tend to bring the lower jaw forward so as to achieve maximum intercuspation. Okay, so what happens in this case? Okay, so what happens when he brings his lower jaw forward? There is the molar relationship tends to become class 3, whereas skeletally it is class 1. So it is a pseudo or functional. Because of the functional problem, the lower jaw is shifting forward. So therefore, what in this case you don't have to go for surgical option or functional correct or for myofunctional therapy. Here you just need to remove the occlusal interference and the jaw go back to its normal centric relation position. So how do you differentiate them clinically? So in clinical scenario, you will ask the patient to slowly close the lower jaw by observing the path of closure of the mandible from rest position to habitual occlusion. Okay, if the patient tend to glide his mandible forward, it is pseudo class 3. And similarly in div 2, what happens? Due to retrocline incisor, patient forcefully to achieve maximum intercuspation tends to have a backward path of closure. So just need to observe and ask the patient to close slowly the lower jaw and see if there is any occlusal prematurity or interference. Okay, so as I told you, the most pathognomic feature of div 2 was deep bite. Similarly, reduced overbite is the most damaging feature of class 3 malocclusion. So this is the differentiating features between true and pseudo class 3. True is class 3 molar caused by lower incisors are lingually inclined and tongue posture is lowered because of the narrow upper arch. Pseudo class 3 caused by, as I told you, forward glide or movement of the mandible into postural habitual class 3, also known as habit, because the patient becomes habitual to close in the forward position. Cause due to occlusal prematurity, I already mentioned. Reasons could be large adenoids, functional reason, or loss of deciduous molars leading to mesial migration of permanent first molars. Moving ahead, the Lister's modification of Angles classification. So Lister in 1933 modified the Angle classification by giving substitute name for Angles classification. For class 1, he called it as neutro-occlusion, class 2 disto-occlusion, and class 3 mesio-occlusion. Okay. Rest, these were the names for the broad. He classified individual tooth position malocclusion as well. So for individual tooth position, he added a term version to it. So for mesial to normal position, mesioversion, distal to normal, distoversion, lingual, linguo, labial, labio. If the teeth is intruded, so infraversion. If it's supraerupted, supraversion. Okay, these are easy. Last 3 becomes your exam questions. So for transposition of teeth, that is from abnormal, so he position. Supposedly canine is erupted in the position of lateral. This is known as transposition. So he gave the term transversion. Next, axiversion. Why? Because of the abnormal axial inclination of teeth. And lastly, rotated teeth के लिए he gave the term torsiversion. So these are the image: mesially inclined, mesioversion, distoversion, palatoversion, labioversion, lingoversion. Palatoversion, labioversion. Okay, infraversion, supraversion, supra-erupted, rotated, torsiversion, rotated, torsiversion, transposition, transversion. Okay, so just remember these names. Next comes the Bennett's classification of malocclusion. So he was the only one who gave it classified based on etiology. Just remember the name. Okay, rest classification is easy, but what is important is based on etiology. So class 1, in which there is abnormal location of one or more teeth due to local factors. Class 2, abnormal formation or a part or whole of the arches due to development defects of bone. And class 3, abnormal relationship of upper and lower arches and or either of those arches because of development defect and facial contours as well. Next, skeletal classification system was given by Salzman. So S for S. Etiology Bennett, skeletal classification by Salzman. He classified it into again 1, 2 and 3. 1 for dental malocclusions, div 1, div 2, div 3, div 4. 2, distal development of mandible, again div 1 and div 2. Div 3, overgrowth of mandible or prognathic profile. Okay, so remember, angle only classified on the molar teeth. It was not worried about the profile or skeletal relationship of the patient. Okay, indirectly he was pointing towards that only, but in his literature he never mentioned about skeletal monitoring. Okay, so just remember, skeletal system was given by Salzman. Okay, I hope it's clear. Next comes the Andrews 6 keys of occlusion. Very important thing. So Andrews 6 keys to normal occlusion given by Dr. L.F. Andrews. If you remember the pre-adjusted edgewise appliance which I discussed during evolution of orthodontic appliance. How this appliance came, because he was the first one to give this first pre-adjusted edgewise appliance, was based on this 6 keys. So what he did was he studied 1200 ortho models which he believed or were treated were to a normal or ideal occlusion. So what is the ideal occlusion? How is this ideal occlusion is there in a patient? He defined them on based on this 6 keys. So this 6 things should be present in that occlusion for it to be classified it as a normal occlusion. So what are these 6 things? First is the molar interarch relationship. Next, mesodistal crown angulation. Third is crown inclination. Fourth is absence of rotation. Fifth is tight contact, and lastly the curve of speech should be flat. Okay, so this is the molar interarch relationship. So first key, the molar interarch relationship, in which first comes cusp fossa relationship. So what, according to him, the mesiobuccal cusp of permanent upper first molar should fall in the buccal groove of lower mandibular molar. Next feature of this, first was cusp fossa, very easy to understand. Next, the distal surface of distobuccal cusp of upper 6 should make contact and occlude with the mesial surface of mesiobuccal cusp of lower second molar. This is with respect to the molars. Next, a cusp embrasure relationship. What is embrasure? From dental anatomy, you know, the space between the two cusps. So the upper premolar and canine should, the cusp of these should fall in the embrasure, or on the buccal surface they should have a cusp embrasure relationship, that the cusp should fall in the embrasure space between the lower premolars and premolar and canine, and on lingual side they should have a cusp fossa relationship, that is their cusp, the lingual cusp should fall in the lower premolars and canines fossa. So this was part of the first key, the molar interact. These all were part of the first key. So according to him, these things should be present for a occlusion to be classified as normal. Next comes crown angulation. So how do we define crown angulation or mesiodistal tip? Angulation or mesiodistal tip. So for that, for an angle you require two lines, and the angle is calculated between them. Okay, so it is generally judged at the mid developmental ridge of crowns of incisor, canines and premolars, and in the molar on the buccal groove of the molars. Okay, so a line passing through the developmental ridge of the canine, incisor and premolar, and through the buccal groove of the molars, and next line through the long axis of the crown and root. So this angle between them, one line, first line on the buccal surface, buccal groove of molars, and mid developmental groove of incisor, canine and premolar, and second line through the bisecting the long axis of the crown and root. So the angle between them is measured, gives you the crown tip. So what is important is, when is this angle positive, when is this negative? This angle is positive when the gingival portion is distal to the incisor portion. Means this is the gingival portion, this is distal. And negative will be reverse to that. So this is crown angulation. Next is crown inclination. I hope it's clear until now, because this is really important for your NEET exam. Andrews 6 keys. In I9 they can ask you arrange the following, correct order, match the following, which key is which key is which. Okay, next is crown and inclination. So inclination is generally seen in the labiolingual or buccolingual direction, that is inclination with respect to the, when we see it from the mesial or distal surface. Okay, again for inclination angle we require two lines. So where are these two lines for get from? So one is the vertical line which is drawn perpendicular to the occlusion plane. So a line perpendicular to the occlusion plane gives you 1. Okay, next passes through the tangent to the facial surface or the buccal surface of the crown portion. So next line tangent to the facial or buccal surface. The angle between them gives you crown inclination. Again it's positive and the gingival portion is lingual to the incisor, means the crown is depressed like this, becomes positive. When it is upright or it's coming outside retrograde, then it becomes negative. Easy to understand. These are the images. Fourth key is absence of rotation or tight contracts. Sorry, this is the fourth key. Yes, I was correct. Absence of rotation or tight contact. So if the teeth are rotated, there will be spacing, and spacing will lead to crowding. Spacing will lead to not a normal occlusion. Next is sixth key, that is flat curve of speech. So absence of rotation and tight contact, fourth and fifth key. So there should be no rotation and there shouldn't be any spacing between the teeth. And lastly, the curve of Sethi should be flat. Okay, later on the seventh key was added by Bolton with relation to the tooth size and arch length. If you remember from model analysis, that there shouldn't be any Bolton discrepancy in the post orthodontic treated case. So as absence of Bolton discrepancy was the seventh key which was given. Next is Simon's classification and canine law. So till now we were relying solely on the position. Angle was relying on permanent first molar as the sole thing behind his classification. Why first molar? I've already told you from our lecture on cephalometry, because of the presence of key ridge in that region, which was given by Atkinson, if you remember. I generally tend to have this recollection or recap because ये एक story के तरह अगर आपकी mind में बन गया, there won't be any reason need to mug it up. Every concept is related to something or else there. Okay, so molar क्यों था classify किया? Molar was because of the key ridge or Atkinson, because key ridge was given by Atkinson. What is key ridge? It was the least modified or least undergoing region in the present in the palate with respect to the roots of the permanent first molar. Okay, sir, is NEET preparation enough for INI-CET also? Yes, it's enough because there is no difference in the syllabus between the two of them. Okay, ऐसा नहीं है कि NEET में ऑर्थो पूछते हैं और INI-CET में they ask you something else, ophthalmology or something like that they start, orthopedics they start to. Both are same, just the type of questions which come is different. Okay, so if you focus more on understanding concepts and all that, you will sail through both of the exam. So or if you start considering them as separate exam कि वो अलग है, उसके लिए अलग पढ़ना है, इसके लिए अलग पढ़ना है, then तो you are in big trouble. Both are same, both are testing your preparation level at the graduation level, Both have same subjects, both have same syllabus. Okay, so coming back to the Simon's classification in canine law, so it is a 3D classification system or a gnatostatic classification of malocclusion. Okay, so it was given by Paul Simon. Okay, and he related the dental arches to the face in the 3 planes of space. Okay, what are the 3 planes he used was Frankfurt plane in the vertical section, orbital plane in the anteroposterior, and the mid-sagittal plane in the transverse section. So these are the 3 planes. Okay. So based on the orbital plane, he classified it as teeth as protracted if they are ahead or retracted if they are behind. In the vertical plane with respect to FH, if they are nearer to the FH, they are attracted or attraction. If they are away, they are known as abstraction. Just English terms are there to understand. In the transverse plane or the mid-sagittal plane, if the teeth are nearer to them, their arches are contracted. If they are away, they are distracted or expanded. Okay, so I have a very limited time. I need to discuss premolar classification system because it's very important for your exam. So I'll be rushing through incisor and canine. So incisor classification system was given by is the British Standard Institute, classified into div class 1, div 1, div 2 and class 3. It was given by Ballard and Wayman in the year 1964 on the works of Backlund. Very easy to understand, nothing much difficult or different. Class 1, div 2, div 1 proclined incisor, div 2 retroclined, and div class 3 in the crossbite. And these all are described in the theoretical format. Canine system similar to the one. Class 1, mesial incline of the upper canine touches the distal incline of the lower. Class 2, the distal incline touches the mesial incline of the lower. And class 3, there is no contact or no overlapping. Now this is very important. It will take some amount of time for this. The Katz premolar system of classification, it was given by Morton Katz in the 1992. So till now students, what we were doing was only classifying malocclusion on qualitative basis, not quantitative. What do I mean by qualitative and quantitative means? Quality means we were just telling them as 1, 2 and 3. We were not measuring them कि कितना class 1 या कितना class 2, how much in mm. So premolar or Katz premolar system was the first one who gave us as qualitative plus quantitative method. Okay, so how qualitative and quantitative, I'll just tell you. Class 1, class 2 and class 3 are very easy to understand. How you to differentiate them is through this image. If you remember from Andrew's 6 key, which I just discussed. So in the canine premolar, on the buccal surface, we have a cusp embrasure relationship. So in class 1, the permanent first molar cusp falls in the embrasure or groove space between the lower two premolar. That becomes class 1. In class 2, it is ahead, class 3 it is behind. So how do you measure it quantitatively? So a line drawn through the long axis of the upper molar and through the embrasure space of the lower premolar. If they are bisecting, it is 0. If it is ahead, it is plus. If it's behind, it is minus. How much mm is ahead? You just need to measure the distance. In your exam, they always give you this in the form of image based like this, and they ask you on the basis of primo. So in NEET INI 2022, there was a certain amount of confusion was created. How come? Because the lines were like this, the upper line was ahead, the lower was behind, but when students saw the image, they saw it as edge to edge relationship. So there was options for class 1, class 2, class 3, and class 4th option was edge to edge, and some students ticked that edge to edge. So pre-Katz never gave this term as edge to edge. In fact, Angle or no one has classified this edge to edge malocclusion relationship. There is no class 4 or type 4 classification in which there are molar the relationships are H to H in any of the classification system till now. This H to H relationship came up during our English language, you can say, but in orthodontic literature or studies, no one has described it as H to H relationship till now. So in exam, you have to look up at these lines. They will always and always draw up these lines if they'll ask you about the premolar classification system. Okay, just remember that. If they ask you in the deciduous and mixed dentition, so you have to take up deciduous molars, because deciduous molars are replaced by permanent premolars. Okay, or if they are lost prematurely, you have to imaginarily draw a line. Okay, so this was the kind of image. If you can look, the relationship is H to H, but the lower upper line is behind, the lower is ahead, so it's class 3. Simple. Next, this controversial question which came up in this exam, the NEET 2025, the Ackermann profit system of classification. Okay, so the Venn diagram, he classified as Venn diagram and collect subsets and all that, which is not important. What is important is this, how to classify, and this caused the problem. Group 1, group 2. So as I've repeatedly told you students, earlier there were more emphasis on relating arches or dental relationship and less emphasis on the soft tissue profile of the patient. So when Ackermann and Profit gave their system in 1969, they classified group 1 as a universal group consisting of alignment and asymmetry of the arches, and group 2 as profile. In the newer system or the current system, these two are interchanged. That is, profile or soft tissue appearances in group 1 and group 2 is alignment and asymmetry of the arches. So if exam mein question aa raha hai, they are not mentioning, then you have to answer according to the newer system, not the older one. Okay, so I stood somewhere or the other, kuch institutes ne they said like this, but I have to, फिर मेरे हमारे students started questioning me, so I have to correct them by giving up references from the newer edition, the 6th edition of the Prophet, okay, to clear their doubt. Okay, group 3 is type, group 4 is class, 5 is bite including deviation in the vertical plane, rest all are easy. 6, 7, 8, 9 are the overlaps between these three. What created trouble was the group 1 and group 2. Two questions came up. One was this diagram based. Okay, they asked to identify which was which, and next was this grouping. Okay, next is Moyer's classification system. It was a bit complicated system. Just remember the name, that class 2 was further classified into horizontal and vertical types, and in horizontal types he gave a 6 system, A, B, C, D, E, F. In vertical 1, 2, 3, 4 and 5. You don't need to remember these types. Okay, so a question, which aspect of malocclusion is most common among the Indian population? So it is crowded teeth, and out of this, mandibular crowding is more common than maxillary crowd. Okay, and oversized lower jaw is more common among the Asian population. That is class 3. Next two terms, that is laterognathy and lateroocclusion. Gnathy is related to skeletal, occlusion is related to dental. Okay, so I have already told you true and pseudo class 3. Lateroocclusion means in the frontal plane. These are looked in the frontal plane or from the front when the upper and lower midline do not coincide in centric occlusion or massive eMedicoz patient, but they coincide in centric relation. That is, when the patient opens, the midlines are coinciding, the upper and lower midline, but when the patient closes, they do not coincide. So it is known as lateral occlusion. That means why it's happening? Because of some occlusal prematurity or occlusal contact, the patient deviates his lower jaw while closing. And laterognathi, the upper lower midline do not coincide either in centric relation or centric occlusion. That is, there is some skeletal component involved. So again, a question, that is, Dockrell's orthodontic equation is related to etiology of malocclusion, treatment outcome, finishing of the case, or patient cooperation. So it is related to etiology of malocclusion. Just remember this. So it is related to, what does it say? That cause, time and tissue results in giving the result for the dentofacial deformity. So related to the etiology of malocclusion. Just remember this name, Dockrell's orthodontic equation. Okay, so with this I close the session. If anyone has any doubt, we can very well write in the comment section. I'll be able to happy to help. So we have a 1 hour session daily at 8 p.m. on the YouTube channel. It's free for all. Anyone can join. Okay, go through them topics. If anyone has any doubt, any suggestion, any topic they want the respective faculty to discuss, you can write in the comment section and we'll be very well able to help you out. Okay, so this is me for Dr. Rijul Agarwal for the orthodontics. Tomorrow we'll have dental histology as the two developmental stages. Okay, so you have this opportunity, take use of it. Okay, and keep on studying. Okay, so no doubts, nothing. So I'll close this session. Thank you.